All right, so now we're recording and we're going to cover GG scoring. You guys just let me know if this leaves the TV at any point, okay? So first off, what is the GG score? The GG score is a functional measure of the resident's usual performance in the first 3 days of the Med-A admission. The score should reflect functional performance before therapy, nursing intervention. GG scoring is also set in the last 3 days of the Med-A stay and whenever an interim payment assessment is done. I went ahead and put this slide in here just in case there was any confusion on the scoring scale, from 6 being the most independent. Your 1 is your dependent. And then the not applicable, not attempted, which is your 7 through 8. Okay. And we can touch on these just a little bit. I think some key things to point out. Mostly they pretty much translate over to our therapy terminology, but it's important to know that dependent is when it requires 2 people. So even if it's 1 person managing some necessary equipment and 1 person providing the assistance, that's considered dependent. So if you have a resident with an oxygen tank that someone's got to manage while you're doing some sort of activity, that's 2 people, that's automatically dependent, okay? So I think that can be a gray area sometimes, but we'll touch on that more throughout the presentation as well. GG scoring, the functional score for PT/OT. So the functional score for the PT and OT components are calculated as the sum of the scores of 10 GG items. So I know on our evals, we've got lots of those little items that pop up. These are the 10 that are pulled from there that actually go into calculating the GG score. So I guess it's worth saying at this point that there's the GG items, the GG score, which is separate from our therapy evaluations, right? Our therapy evaluations list what we did that day, list what our true and accurate information, what actually happened with the patient with us that day, which is separate from the GG score, which is the patient's usual performance for the first 3 days of their stay. So we may make changes to that GG score in those first 3 days based off of their performance and who provides their care, but we're not making changes to what happened during the eval. Okay, so if there's any questions about that, let me know. But when I say we'd go back and change something, I'm not talking about our plan of care, our evaluation. That's what happened with us from a therapy perspective that day. The GG score is something completely separate that gets discussed with the interdisciplinary team. So, you've got your therapy representative, you've got MDS, nursing, all the whole gamuts in there, just talking about what we believe to be true for that resident's usual performance for the first 3 days. Okay, so we'll get more into that a little bit too. But the 10 items are the 2 bed mobility items, 3 transfer items, 1 eating item, 1 toileting item, 1 oral hygiene item, and 2 walking items. We're going to be going over more than that, but I just want you guys to know those are the 10 items that go into the actual total score. This is some important information on this slide about the discharge goal setting. So realistic discharge goal setting and the needs of the discharge location are extremely important. That's not a shocker, right? The reason we point this out for GGs is because when we're setting our admission performance for that resident in the GG section, you guys, especially my evaluating therapists in here, know that it also asks us to set a discharge goal. And as clinicians, we all say we want everyone to be independent, right? That's what we want for people. But we have to make sure we're really applying that clinical knowledge to say what is appropriate, realistic, and necessary for this person and setting them at that. So I'll go through this and then we'll see if that makes sense to y'all. If therapy is setting goals that are too high and the resident does not attain them, the facility's quality measures can be negatively affected. We all want our residents to be safe and independent, but consider if that is a realistic goal for that activity. Remember that many residents can return home even if they are not completely independent. Depending on caregiver support, they may be able to safely discharge at minimal assistance or supervision level. If this is the case, then we don't need to set these folks at independent. Does that make sense? So look at it in terms of we're the PT, OT, ST experts, not necessarily ST because ST doesn't do GGs, but we are saying that we think and feel that this person needs to be at this level to go home safely. And if we're saying that it's independent, but really they live with their daughter and the daughter does meals and dressing for them, then is independent really the most realistic and necessary goal? Okay? Because home health can, and outpatient services, we all know that from doing outpatient here, right? So, but those exist to help them get to the next level. Our job is to get them home. General coding tips. Clinical assessments may include any device or equipment that the resident can use to allow them to complete the activity as independently as possible. The important sidebar here is that we can introduce new equipment to a resident, right? We don't necessarily need to code them at a higher level of assistance because we introduced a new piece of equipment. If we do have to give cues, education, strategies, or tactile assistance for them to successfully use this piece of equipment, then we're doing therapy, right? So then an intervention has started. And the definition of a GG is that it's a usual performance before an intervention. So you really have to use your clinical judgment there. Did they need therapy to intervene to use this piece of equipment safely and efficiently? And the second they do, we're not doing GG scoring anymore, we're doing therapy. Okay? The other situation to think about there is if the resident already used a walker at home, then that's what they're used to. We're not doing any therapy. That's their piece of equipment from prior level. Okay. Do not code self-care and mobility activities with use of a device that is restricted to the resident's use during therapy. So this is like parallel bars. That's clearly therapy intervention, right? Or some of your overhead track and harness systems, which we don't have here, but they do exist in some clinics. Things that require the skill of the clinician or for the patient to use successfully, right? Because that's not a usual performance. That's therapy. Not applicable means that the resident does not perform this activity and will not in the future. If not applicable is selected initially, not applicable should also be scored for that item anytime the GGs are assessed in the future. So any additional assessments you're going to have not attempted because you're saying they did not do it before they got here and we don't expect that they're going to do it anytime during their stay here or when they return home. Do not switch back and forth from the NA to refused or to dependent. Okay, those are separate scoring items. If the resident requires 2 people to perform the activity, regardless of how much physical assistance each person is providing, the GG score is dependent, even if the second person is only managing necessary equipment to complete the activity safely. If the resident refuses to perform an activity on the initial eval, but does perform that activity within the first 3 days, the refusal should be removed, not from your eval, because that's what happened during your eval, but from the GG scoring set. And the actual assist level should be entered for that item. So that's something you would communicate with your program manager about. And then that would be edited based off of the findings. Here are your self-care items. I'm just going to read them off. We've got eating, oral hygiene, personal hygiene, toilet hygiene, washing upper body, showering, bathing self, upper body dressing, lower body dressing, and putting on and taking off footwear. So we'll start with eating. Eating, and as far as GGs are concerned, is defined as the ability to use suitable utensils to bring food to the mouth and to swallow food once the meal is presented on a table or tray. It includes modified food consistencies. So some of you SLPs who wonder why I'm making you sit through this, it's because there's some overlap here, right? These are things that you might see during your sessions that we can talk about as a group. If a resident is able to swallow safely without assistance, then we exclude swallowing from the consideration while coding. For a resident taking only fluids by mouth, this item may be coded based on the ability to bring the liquid to the mouth and swallow the liquid once the drink is placed in front of the resident. Assistance with tube feedings are not considered when coding this item. Okay. Oral hygiene is defined as the ability to use suitable items to clean teeth. For dentures, it's the ability to remove and replace your dentures from and to mouth and manage equipment for soaking and rinsing. For a resident who is edentulous, which means they don't have teeth, and they don't have dentures, you're going to code oral hygiene based on the type and amount of assistance required from a helper to clean the resident's gums, which my SLPs and probably my OTs in here will tell you how important it is for oral hygiene, even if they don't have teeth, right? Because all the bacteria that grows there. So that I'm going to get off on a soapbox here, so I'll reel back in. Personal hygiene, the ability to maintain personal hygiene, including combing hair, shaving, applying makeup, and washing and drying the face and hands. It does not include baths, showers, or oral hygiene. Toilet hygiene, the ability to maintain perineal hygiene, adjust the clothes before and after using toilet, commode, bedpan, or urinal. This includes managing clothing, including undergarments and incontinence products such as briefs or pads, before and after voiding or having a bowel movement, and adjusting clothing relevant to the individual resident. When a resident requires different levels of assistance to perform that whole task, so hygiene versus after voiding versus after a bowel movement, which can vary based on assistance needed, code based on the type and amount of assistance required to complete the entire activity. If managing an ostomy, you can include opening or wiping the opening, but not managing the equipment. Okay, so it's hygiene for that area, but not managing the actual colostomy bag and cleaning that. Washing upper body, the ability to wash, rinse, and dry the face, hands, chest, and arms while sitting in a chair or bed. Shower, bathe self. The ability to bathe self in a shower or tub, including washing, rinsing, and drying self. This does not include transferring in and out of the tub or shower or washing the back or hair. It can take place in any location. This is good to know for some of our facilities who require day one shower assessments or bathing assessments, right? Can take place in any location, including a shower or bath, or at a sink or in bed. Full body sponge bath. Bathing can be assessed with the resident seated on a tub bench. If a resident cannot bathe their entire body because of a medical condition, so they have a cast or a non-removable dressing, then code based on the amount of assistance needed to complete the activity for that item. Set up cleanup assistance if the only help the resident requires is assistance before the bathing activity to cover wounds or devices for water protection during bathing. Upper body dressing, the ability to dress and undress above the waist, including fasteners. If the resident requires assistance with dressing, include assistance with buttons, fasteners, and/or fastening a bra. Code based on the type and amount of assistance required to complete the entire dressing activity. So when it's saying that, it's saying don't just take snapshots of an activity, record the highest level of assistance they needed to complete that whole activity, right? So if a portion of the activity took min assist, but at some point they needed maximal assist, you would code maximal assist, okay? Lower body dressing, the ability to dress and undress below the waist, including fasteners, do not include footwear. This does also include your prostheses, right? Your transfemoral or your transtibial prostheses are considered lower body dressing. Okay. Putting on, taking off footwear. The ability to put on and take off socks or shoes or other footwear that is appropriate for safe mobility, including fasteners. So this does include our grip socks that we use with a lot of residents. If the resident has a chronic bilateral amputation, you would code 09. Because they did not, as we got it on this little list right here, not applicable, the resident did not perform this activity prior to the current injury, exacerbation, or the current injury. So that sums up, in short or long, our self-care items. And these are our mobility items, which they're a little bit more extensive than our self-care, but we've got rolling left and right, sit to lying, lying to sitting on side of bed, sit to stand, chair and bed to chair transfer, toilet transfer, tub shower transfers, car transfer, excuse me, walking 10 feet, walking 50 feet with 2 turns, walking 150 feet, walking 10 feet on an uneven surface, 1 step or curb, 4 steps, 12 steps, picking up an object, wheeling 50 feet with 2 turns, and wheeling 150 feet. So for any of the PTs in here, this is what shows up on our eval on the functional mobility side. Roll left and right. The ability to roll from lying on back to left and right side and return back to lying on the back of the bed. If the resident does not sleep in a bed, clinicians should assess bed mobility activities using alternative furniture on which the resident sleeps. For example, some of our folks say that they don't sleep in a bed at home, they sleep in a recliner, right? So you want to use clinical judgment there when you're assessing their admission performance and say, are we going to consider this piece of equipment, the bed they're in now, for a significant period of time while they're here to be the piece of furniture they're going to be sleeping on? Yes. If you do have access to a recliner, and that's what they were using at home, which some of our facilities do, some don't, then that would be the best option. If neither one of those are applicable, then you would put the activity was not attempted. Sit to lying, the ability to move from sitting on the side of the bed to lying flat on the bed. For lying flat in bed, if there is a physician order in place for the head of bed slightly elevated, the resident can continue to be assessed for this bed mobility task. If the resident has to sleep upright in bed, you would not be able to assess this task. Lying to sitting on the side of the bed, the ability to safely move from lying on the back to sitting on the side of the bed with no back support. This used to say with feet flat on the floor, they took that out. So you just want to take into consideration that with no back support, because our hands are back support, furniture is back support. Sit to stand, the ability to safely come to a standing position from sitting from any sitting surface. It used to say sitting in a chair or on the side of the bed, but now it's any sitting surface, which gives us a little bit more flexibility. If a full body mechanical lift is needed for the resident to transfer chair bed to chair, then you would code the sit to stand with the appropriate activity not attempted code. Code setup or cleanup if the resident only needs assistance to retrieve DME or adaptive equipment such as a front wheeled walker or an AFO. Okay. So if we have to use a mechanical lift such as a Hoyer lift for sit to stand, that's going to be that the activity was not attempted. You choose the right not attempted code, which would probably be medical safety for this one. So that is going to be your 8-8, not attempted due to medical condition and safety concerns. If they need 2 people or one of your sit to stand lifts, they're still completing the activity, right? Sit to stand, they would be dependent. So the difference there is with a mechanical lift, a Hoyer lift, they're not completing the sit to stand activity. They're being lifted and placed on it from one surface to another. They never did the sit to stand portion, so they can't be graded on that, right? They can't be scored on that when it didn't happen. If it's 2 people or a sit to stand lift, they are completing that action. We can score them dependent. Okay, chair, bed to chair transfer, the ability to safely transfer to and from a bed to a chair or wheelchair. Depending on the resident's abilities, the transfer may be a stand pivot, squat pivot, or a slide board. I think we forget about that too. We think slide board's automatically dependent. That counts as a chair, bed to chair transfer. When assessing the resident moving from chair, bed to the chair, the assessment begins with the resident sitting at the edge of the bed or an alternative sleeping surface and ends with the resident sitting in a chair or wheelchair. When assessing the resident moving from the chair to the bed, the assessment begins with the resident sitting in the chair or wheelchair and ends with the resident returning to a sitting at the edge of the bed or alternative surface. Sit to lying and lying to sitting are 2 separate activities that are not assessed as part of this item. Okay, so it's just saying for this item, you're not going to code starting with them lying to sitting and back. You're just going to look at the chair, bed to chair component. The transfer should be assessed in an environmental situation in which taking more than a few steps would not be necessary. So you're not, some of our rooms, I think we have sofas that are a significant distance away from the bed. You're not going to do a bed to chair, bed to couch transfer and count all those steps, you know, the level of assistance it took to get from the bed to the sofa with someone, right? You're just thinking about that actual transfer component. Toilet transfer, the ability to safely get on and off a toilet or commode. If the resident requires a helper to position or set up the bedside commode before and after the resident's bed to commode transfers, place in an accessible angle location next to the bed, and the resident does not require helper assistance during toilet transfers. Tub shower transfer. The ability to get into and out of the tub or shower do not include washing, rinsing, drying, or any other bathing activities. So it's just that component, the tub shower transfer. If the resident does not get into or out of the tub and or shower during the observation period, use one of the activity not attempted codes. Setup and cleanup of equipment needed to complete the activity, including a tub bench, is considered when coding this item. Car transfer, the ability to transfer in and out of the car or van on the passenger side. Does not include getting to or from the vehicle or the ability to open or close the door or fasten the seatbelt. If the resident remains in a wheelchair and does not transfer in and out of the vehicle when the item is coded using the appropriate activity not attempted code. The assistance needed to manage an assisted device that is used to get to and from the vehicle should not be considered when you score this item. And now we're to our walking items. The assessment of the walking activity starts with the resident in a standing position. Okay, so we're not doing the sit to stand transfer and scoring that they were min assist for that or partial mod to use our scoring terminology. And then, factoring that into the whole activity. You're just scoring them from when they're standing and they start taking those steps to complete the walking items. A walking activity cannot be completed without some level of resident participation that allow ambulation to occur for the entire stated distance. A helper cannot complete a walking activity for a resident. So this seems kind of odd wording anyway, but that's just saying that you can't have someone upright and be completing the whole movement for them and them not participating at all, even if it's two people. That would be that the activity wasn't completed versus dependent if it was two people and the resident was participating. During a walking activity, a resident may take a brief standing rest break. So you're walking, they've made it 5 feet. They say, hang on a second, let me just, let's just take a minute, and then they keep going. You can continue. The thing goes for the 50 feet and the 150 feet. If they sit, they did not complete that activity. Okay, there's no seated rest break in scoring these items. So if the resident needs to sit to rest during the activity, consider the resident unable to complete the walking activity and use the appropriate activity not attempted code, which is going to be your safety code. If the environment does not accommodate a walk, because we all remember isolation issues, right? And we still have them. If the environment doesn't accommodate a walk for the total distance, so you're 10 feet, you're 50 feet, you're 150 feet, you may consider walking with multiple turns to equal the total footage as long as it does not jeopardize the resident's safety. So you can't leave the room, right? And you're like, well, we can't do 150 feet then. Not by definition of the GG score, right? We can still do 150 feet as long as we don't make ourselves or the resident dizzy in that room. If they can't do it safely, then it's not attempted due to safety, right? But that option is there. Clinicians can use clinical judgment to determine how the actual resident assessment of walking is conducted. So this is not to be confused with, well, they've made it 5 feet. How do I think they would have done with 10 feet? That's not what we're saying. What this is saying is we walked 150 feet. I'm going to think about how much assistance they needed at the 10-foot mark. I'm going to see think about how much assistance they needed at the 50 feet with 2 turns mark and how much assistance they need at the end of that 150 versus let's walk 10 feet. Okay, sit down. Hang on. Let's walk 50 feet with 2 turns. Okay, great. Let's walk 150 feet. You don't have to do those separately. You can kind of break it down every step of the way for the stated walking distance. So the fancier way of saying that is if you choose to combine the assessment of multiple walking activities, then you should use clinical judgment to determine the type and amount of assistance needed for each separate activity. Use clinical judgment when assessing activities that overlap or occur sequentially to determine the type and amount of assistance for each individual activity. So the walking items are a little bit more black and white. You've got walking 10 feet. Once standing, the ability to walk at least 10 feet in a room, corridor, or similar space. If admission performance is not assessed, you skip to 1 step. Because you're not gonna, if they can't do 10 feet for whatever reason or didn't do 10 feet, you're not gonna necessarily look at 50 or 150 feet, right? Walking 50 feet with 2 turns is once standing, the ability to walk at least 50 feet and make 2 turns. The turns included in this item are 90-degree turns. They can be in the same direction or opposite direction. So you can make 2 left turns, you can make a left turn and a right turn, but it has to be 2 separate 90-degree turns. Walking 150 feet, once standing, the ability to walk at least 150 feet in a corridor or similar space. Walking 10 feet on an uneven surface. So the ability to walk 10 feet on an uneven or sloping surface, indoor or outdoor, such as turf or gravel. And now we're on to our step items. Completing the stairs activity indicates that the resident went up and down stairs by any means, with or without handrails, assistive device, or equipment such as a walker, cane, crutch, stair lift, and or with or without some level of assistance. Getting to and from the stairs is not included when coding curb step activities. Ascending and descending stairs does not have to occur sequentially during one session. If these do occur sequentially, the resident may take a standing or seated rest break between ascending and descending 4 steps or 12 steps. A resident who uses a wheelchair may be assessed going up and down stairs. So I usually get some looks at that point about using a wheelchair to go up and down steps. So if you look above a little bit, it says, the resident went up and down stairs by any means. So that means walking up and down with a stair lift, walking up and down using the handrail. For some of our residents, that means going home and bumping up and down or scooting up and down on their bottom. And that also means for some of our higher level neurologically involved patients, maybe a younger spinal cord injury resident, someone who uses one of those sport wheelchairs, they do often go up and down curbs and wheelchairs or up and down curbs and stairs with their wheelchairs. That's probably not going to happen in this environment. If it does, please phone all of us so that we can come learn from that situation. And it is my strong encouragement. I strongly encourage you not to try that with any of our little people who are going to be leaving here and going home. If you guys do find yourself in that situation, please let us know so we can work with you on it. But that does exist as an option for coding stairs. So I just wanted to put that out there. One step or curb is the ability to go up and down a curb and or up and down one step. If the admission performance is not completed, skip to P, which is picking up an object. Assess the resident going up and down one step or up and down or over a curb. If both are assessed, then you're going to score them based off of the activity that required more assistance. 4 steps. The ability to go up and down 4 steps with or without a rail. If the admission performance is not assessed, you're going to skip over. You're not going to go ahead and go on to 12 steps, right? Because it wouldn't be applicable here. 12 steps, the ability to go up and down 12 steps with or without a rail. A lot of our residents aren't doing that before they get here, but some are. If the environment does not have 12 steps, like our stair situation here, the combination of going up and down 4 stairs 3 times consecutively in a safe manner is acceptable to meet the requirements for this activity. Picking up an object. The ability to bend, stoop from a standing position. So that's important, right? Because I think a lot of us look at this and we go ahead and think about picking up an object from wheelchair level. That is not a part of this item. It's the ability to bend and stoop from a standing position to pick up a small object such as a spoon from the floor. Assistive devices and adaptive equipment may be used, so cane, walker, and or reacher. So they can still use a reacher, they just need to be standing. If the resident uses a reacher in the standing position with a helper supporting the upper body or providing assistance, then code based on the amount of effort the helper provides. If the helper or therapist gives or hands the resident the resident maintains balance while standing and picks up the object, code setup or cleanup, which is item number 5. Wheelchair items. If the resident used a wheelchair for self-mobilization prior to admission to the facility, code wheelchair yes and proceed with subsequent questions. So this wheelchair item is like a gateway item. You're going to say yes or no based on their prior level or based on their prognosis here, what their current situation is, and that could change throughout their care. Okay, if you say yes, it's going to cue more questions. If you say no, it moves you on to the next item. Is the wheelchair for staff convenience or is it a transport wheelchair? Then the answer should be no. Or is it due to medical condition or safety? If the answer is due to medical condition or safety, proceed with the subsequent questions. The responses do not have to be the same on subsequent assessments. So as some of you know, there are situations where we do additional assessments and our evaluating therapists know that we revisit these items on our anchor documents, like our progress notes, updated plans of care. So if you say no at first, that may be different down the line because the discharge plan changed, their progress, the level of progress that you expected them to make, they did not make, things like that, that have changed throughout their course of treatment that allow us to make changes for what we think is ideal for them. So the responses do not have to be the same. So the admission assessment indicates the resident does not use a wheelchair, but the subsequent assessment indicates the resident does use a wheelchair. If the environment doesn't accommodate wheelchair scooter use for the total distance, you may consider completing multiple turns, just like with the walking items, to equal the total footage as long as it does not jeopardize the resident's safety. Wheeling 50 feet with 2 turns, once seated in a wheelchair or scooter, can wheel at least 50 feet and make 2 turns. Wheeling 150 feet can wheel at least 150 feet in a corridor or similar space. A helper or therapist can assist a resident in completing the required distance in the wheelchair or making turns if needed. When a resident is unable to wheel the entire distance themselves, the activity can still be completed and a performance code can be determined based on the type and amount of assistance required to complete the entire activity. And I think this will be good news because the next slide is our references slide. And then this is our questions slide. So if anybody has any questions, please feel free to reach out to any of your clinical specialists. And for those who I'm here in front of, I will go ahead and answer those here in just one moment. And I'm going to conclude this recording.